47%. That's how much sleeping on your right side increases nocturnal blood pressure compared to left side sleeping, according to a 2023 study published in the Journal of Clinical Sleep Medicine from researchers at Mount Sinai Medical Center. 47% higher pressure on the vessels feeding your brain while you're unconscious for 8 hours every single night. Not from a disease, not from a medication side effect, from something as simple as which side of the bed you roll toward when you close your eyes. And here's what makes this criminal. Cardiologists have known about positional hemodynamics for 3 decades. The research isn't hidden in some obscure journal nobody reads. It's published in Circulation, in the American Heart Journal, in peer-reviewed publications that every cardiologist in America has access to. So why isn't your doctor asking which side you sleep on during your annual physical? Why isn't this on the checklist right next to blood pressure and cholesterol? Because there's no prescription for sleeping position. There's no patent on turning left instead of right. Pharmaceutical companies can't make $1,400 monthly selling you a pill that tells you to change sides. So they don't fund the research, they don't promote the findings, and your doctor who sees you for 12 minutes between insurance paperwork never mentions it. Over the next 28 minutes, this presentation will walk through 7 sleeping positions ranked from least risky to most dangerous for stroke prevention in adults over 65. The number 1 position, when the data is examined closely, creates hemodynamic conditions in the carotid arteries and cerebral circulation that mirror what happens during transient ischemic attacks. The mechanism is proven. The measurements are published. And nobody told you. If seniors deserve complete information about stroke prevention, not just whatever generates the most prescription revenue, there needs to be engagement with this content right now. Only pharmaceutical executives profiting from keeping this information suppressed won't subscribe. Hit that subscribe button and turn on notifications, because the algorithm buries health content that threatens medication sales. Every subscription tells them this information will not stay hidden. Before examining the 7 positions, understanding why sleep position matters requires brief explanation of nocturnal cardiovascular dynamics. During sleep, blood pressure naturally decreases 10 to 20% in what researchers call nocturnal dipping. This dipping provides cardiovascular rest, reducing strain on vessel walls and allowing repair processes. However, body position dramatically influences venous return, cardiac output distribution, and pressure gradients throughout the vascular system. The heart sits slightly left of center in the chest cavity. When lying on the right side, gravity pulls the heart rightward, creating mechanical compression of the right atrium and vena cava. This compression reduces venous return efficiency while simultaneously increasing pressure in the aortic arch and carotid distribution. Research from Lund University in Sweden, published in 2022 in Hypertension Research, measured real-time blood pressure changes during position shifts in 240 participants aged 62 to 79. The findings showed systolic pressure increases of 12 to 18 millimeters of mercury when moving from left side to right side sleeping, with the increase sustained throughout the night. 18 millimeters might sound modest, but over 8 hours of sleep, over 365 nights yearly, over a decade of retirement, that cumulative vascular stress creates measurable stroke risk elevation. Position number 7, the least optimal but still better than what follows, involves sleeping flat on the back with head elevation below 15 degrees. Back sleeping, called supine position in medical literature, creates several problematic dynamics for seniors managing cardiovascular risk. Gravity distributes blood flow evenly across both cerebral hemispheres, which sounds beneficial, but actually reduces the natural pressure gradient that promotes efficient drainage through jugular veins. A 2021 study from the University of Toronto published in the Journal of Neurology examined 187 seniors with existing carotid stenosis, narrowing of the neck arteries that supply the brain. Participants who primarily slept supine showed 23% higher incidence of nocturnal desaturation events, periods where brain oxygen levels dropped below optimal thresholds. The mechanism involves gravitational effects on the tongue and soft palate. In supine position, these structures fall backward, partially obstructing the airway. Even without diagnosed sleep apnea, this creates intermittent breathing disruptions, reducing oxygen delivery to already compromised cerebral circulation. Additionally, supine sleeping increases intracranial pressure, the fluid pressure surrounding the brain. Research published in Neurocritical Care in 2020 showed that supine position elevated intracranial pressure by an average of 4 to 7 millimeters of mercury compared to lateral positions. For seniors with existing hypertension or cerebrovascular disease, this additional pressure stresses vessel walls already damaged by decades of elevated systolic readings. Robert was 73, a retired accountant from Kansas who'd managed his blood pressure with lisinopril for 16 years. His numbers stayed controlled, usually 130/82, sometimes better. He slept on his back his entire life, the way his father slept, the way he'd always been comfortable. Then one morning he woke up and his right hand felt strange. Not numb exactly, but weak, clumsy. He couldn't button his shirt properly. His wife noticed his face looked slightly asymmetric, the right corner of his mouth drooping almost imperceptibly. They went to the emergency room. The CT scan showed a small ischemic stroke in the left motor cortex, the area controlling right side movement. Not massive, not catastrophic, but enough to affect his dominant hand function. The neurologist asked about sleep position during the intake. Robert mentioned he slept flat on his back. The neurologist noted it in the chart but said nothing about changing it. 3 months later, during cardiac rehabilitation, a different physician mentioned the research about supine sleeping and stroke risk. Robert started sleeping on his left side with a pillow supporting his back to prevent rolling. 18 months later, he's had no additional events. His hand function recovered about 70%. He wishes someone had mentioned sleep position before the stroke rather than after. If this information about something as fundamental as how the body is positioned during 1/3 of life is surprising, if a doctor never mentioned this during any cardiovascular consultation, that like button needs attention right now. Not for algorithm gaming, but because every like signals to the platform that seniors want complete health information, not just information that generates prescription revenue. The pharmaceutical model depends on viewers remaining partially informed, educated enough to take medications, but ignorant of free interventions that might reduce pharmaceutical dependency. Position number 6 introduces slight improvement through upper body elevation, but maintains problematic supine orientation. This involves sleeping on the back, with the head elevated 25 to 35 degrees, often achieved through adjustable bed frame or wedge pillow arrangement. The elevation reduces some gravitational compression on cerebral vessels and decreases the tongue obstruction dynamic that creates desaturation. Research from Johns Hopkins, published in Sleep Medicine in 2023, examined elevated supine sleeping in 142 participants with diagnosed hypertension. The study found that 30-degree elevation reduced nocturnal blood pressure by an average of 6 millimeters systolic compared to flat supine position. The mechanism involves gravitational assistance with venous drainage from the brain through jugular veins back toward the heart. When the head sits higher than the heart, blood doesn't pool in cerebral circulation, reducing the volume of blood the brain must process and decreasing intracranial pressure. However, elevated supine sleeping creates a different problem that research only recently identified. A 2024 study from the University of Pittsburgh, published in the American Journal of Cardiology, examined long-term effects of chronic elevated sleeping in seniors with existing coronary disease. The findings showed that sustained upper body elevation redistributes blood volume toward the lower extremities. Over 8 hours nightly, this redistribution can reduce cardiac filling pressures, decreasing stroke volume, the amount of blood the heart pumps with each beat. In seniors with borderline cardiac function, this reduction sometimes triggers compensatory increases in heart rate, forcing the heart to work harder to maintain adequate circulation. Additionally, the elevated position sometimes creates lower back strain, causing poor sleep quality that increases inflammatory markers associated with cardiovascular disease progression. The Pittsburgh research found that seniors sleeping in elevated supine position reported 34% higher rates of middle-of-the-night awakening compared to lateral sleeping positions, and this sleep fragmentation correlated with measurable increases in C-reactive protein, a marker of systemic inflammation linked to atherosclerotic plaque instability. Position number 5 moves away from back sleeping entirely, introducing right lateral position with minimal upper body support. Right-side sleeping, while better than supine positions for airway maintenance and sleep apnea reduction, creates the hemodynamic challenge mentioned in the opening. When lying on the right side, the heart's anatomical position shifts rightward under gravitational influence. This shift compresses the inferior vena cava, the large vein returning blood from the lower body to the heart. The compression reduces venous return efficiency, forcing the heart to generate higher pressures to maintain adequate circulation. Simultaneously, the aorta, the body's main artery exiting the left ventricle, experiences altered pressure dynamics. The aortic arch, the curved section where major arteries branch toward the brain, sits in a position where right-side sleeping increases mechanical stress on the vessel wall. Research from the Mayo Clinic published in Circulation in 2022 used overnight pressure monitoring in 193 participants aged 64 to 76. The data showed that right lateral sleeping increased carotid artery pressure by an average of 12 to 15 millimeters of mercury compared to left lateral sleeping. This might seem modest, but carotid pressure directly influences stroke risk. The carotid arteries are the primary blood supply to the brain. Any sustained pressure increase in these vessels accelerates atherosclerotic plaque development and increases rupture risk of existing plaques. The mechanism involves endothelial shear stress, the friction blood flow creates against vessel walls. Higher pressure means faster flow velocity, and faster velocity means greater shear forces. These forces damage the endothelium, the thin cell layer lining blood vessels. When endothelial cells are damaged, they become permeable to low-density lipoprotein cholesterol, allowing LDL particles to infiltrate the vessel wall where they oxidize and trigger inflammatory responses that build arterial plaques. Additionally, higher pressure increases wall tension, the stretching force on vessel walls. Chronic increased wall tension leads to arterial stiffening, reducing the vessel's ability to expand and contract with each heartbeat. Stiff arteries can't cushion pressure surges as effectively, creating higher peak pressures that further accelerate damage. A meta-analysis published in the European Heart Journal in 2023 examined data from 17 studies involving over 4,000 participants and found that individuals who predominantly slept on their right side showed 18% higher 10-year stroke risk compared to left-side sleepers, even after controlling for blood pressure, cholesterol, diabetes status, and medication use. Patricia was 68, a retired postal worker from Arizona, married 41 years, 3 grandchildren, walked 2 miles every morning without fail. Her blood pressure ran slightly high, usually 140/88, managed with losartan 50 milligrams daily. She'd always slept on her right side, curled slightly, hugging a pillow. Comfortable, familiar, the way she'd slept since childhood. During a routine carotid ultrasound ordered because of a brief episode where her vision went blurry for about 90 seconds, the technician found moderate plaque buildup in her right carotid artery. Not severe enough for surgery, but enough to warrant monitoring and possible medication intensification. Her cardiologist mentioned, almost in passing, that sleeping position might influence carotid pressure. He suggested trying left-side sleeping. Patricia thought it sounded absurd, pseudoscience. Something from a wellness blog, not a cardiologist. But the ultrasound image showing that plaque scared her enough to try. The first 2 weeks felt impossible, uncomfortable, like sleeping in someone else's bed. She kept rolling back to her right side unconsciously. She started using a body pillow behind her back, creating a physical barrier preventing the roll. After 3 weeks, left-side sleeping started feeling natural. 14 months later, her follow-up ultrasound showed no plaque progression. The cardiologist called it stable disease. Patricia wondered what might have happened if she'd changed sides 5 years earlier, before the plaque developed. At approximately the halfway point, there needs to be acknowledgement of something disturbing. Everything covered so far, the hemodynamics, the pressure gradients, the carotid studies, this information exists in published medical literature. It's not speculative. It's not alternative medicine. It's cardiovascular physiology documented in peer-reviewed journals. Yet, how many seniors managing hypertension, managing cholesterol, managing diabetes, all conditions that increase stroke risk, have ever had a physician ask about sleep position? The answer is almost none. Why? Because the medical system is structured around interventions that generate revenue. A 12-minute appointment allows time to refill amlodipine and check blood pressure. It doesn't allow time to discuss sleep ergonomics that cost nothing and generate zero pharmaceutical revenue. If this makes sense, if there's recognition of how profitable healthcare creates systematic blind spots in patient education, that share button needs activation right now. Share this with every senior managing cardiovascular risk, every spouse, every friend from church or the community center who's on blood pressure medication and has never been told that sleep position matters. The algorithm won't show them this organically. It has to be sent directly. Position number 4 introduces optimal lateral orientation, but suboptimal execution through inadequate support structure. This involves sleeping on the left side without proper spinal alignment or pressure distribution. Left lateral sleeping provides the gravitational advantages discussed while avoiding the hemodynamic compression of right side sleeping. However, without adequate pillow support, left side sleeping creates musculoskeletal stress that fragments sleep quality. The spine needs to maintain neutral alignment during sleep, meaning the cervical spine, the neck, should form a straight line with the thoracic and lumbar spine when viewed from behind. When sleeping on the left side without proper pillow height, the head tilts downward, creating lateral flexion of the cervical spine. This misalignment compresses nerve roots exiting the spinal cord, sometimes causing arm numbness or shoulder pain that triggers awakening. Research from the University of Michigan, published in the Journal of Sleep Research in 2021, found that lateral sleeping without ergonomic pillow support increased sleep interruptions by 41% compared to properly supported lateral positions. Sleep fragmentation increases sympathetic nervous system activation, the fight-or-flight response, which elevates heart rate and blood pressure. A study in hypertension in 2020 showed that poor sleep quality increased daytime blood pressure by an average of 8 millimeters systolic and 5 millimeters diastolic, effectively negating the benefits of many antihypertensive medications. Additionally, unsupported left lateral sleeping sometimes creates excessive pressure on the left shoulder and hip, compressing soft tissues and reducing blood flow to these areas. This compression triggers position changes during sleep, brief movements where the body shifts to relieve pressure. While these micro-adjustments happen unconsciously, each movement partially awakens the brain, preventing deep sleep stages essential for cardiovascular recovery. The cumulative effect is spending 8 hours in bed, but getting only 5 or 6 hours of restorative sleep, creating a chronic sleep debt that increases stroke risk through multiple pathways, including increased inflammation, elevated blood glucose, and higher cortisol levels. Position number 3 demonstrates significant improvement through combining optimal orientation with proper support structure. This involves sleeping on the left side with ergonomic pillow arrangement, maintaining neutral spinal alignment, and distributing pressure across multiple contact points. The pillow under the head should be thick enough to fill the space between the shoulder and head, keeping the neck in neutral position. A pillow between the knees prevents the top leg from pulling the spine out of alignment and reduces hip pressure. Some individuals benefit from a small rolled towel supporting the waist, preventing the torso from tilting forward or backward. Research from Stanford Sleep Medicine Center, published in Sleep in 2023, examined sleep architecture in 174 participants using proper left lateral support versus unsupported positions. The data showed that properly supported left lateral sleeping increased time spent in deep sleep stages by 28% and reduced nighttime arousals by 36%. This improvement in sleep quality correlated with measurable cardiovascular benefits. Nocturnal blood pressure dipping, the healthy decrease in pressure during sleep, was more pronounced in the supported left lateral group, averaging 16% reduction compared to 11% in unsupported sleepers. The hemodynamic advantages of left lateral sleeping become more pronounced with proper support because sustained positioning allows cardiovascular adaptations to develop. When the body remains in stable left lateral position for extended periods without interruption from discomfort-related position changes, venous return achieves optimal efficiency. The heart sits naturally oriented with minimal gravitational compression. The aorta experiences reduced wall stress. Carotid pressure remains in the lower range of normal. Over 8 hours nightly, over months and years, these subtle advantages accumulate into measurable risk reduction. A longitudinal study from the Framingham Heart Study Extension, published in the American Journal of Cardiology in 2024, followed 1,263 participants aged 60 to 80 for an average of 9.3 years. The research found that individuals who consistently slept in supported left lateral positions showed 24% lower incidence of stroke compared to mixed position sleepers, after adjusting for traditional risk factors including hypertension, diabetes, smoking history, and cholesterol levels. 24% risk reduction from something as simple as which side to sleep on and using appropriate pillows. That's comparable to the risk reduction from some statin medications, except sleep position modification costs nothing and produces zero side effects. James was 71, a retired electrician from Oregon, managing type 2 diabetes with metformin, hypertension with amlodipine, and high cholesterol with atorvastatin. His 10-year stroke risk calculated at 17% based on the Framingham risk score. He'd always been a restless sleeper, moving between back, right side, left side, stomach, cycling through positions throughout the night. He'd wake up with neck pain, shoulder stiffness, feeling unrested despite 8 hours in bed. During a routine neurology appointment following some episodes of lightheadedness, the neurologist asked about sleep. James described the position's cycling and morning stiffness. The neurologist suggested trying consistent left side sleeping with proper pillow support, explaining the cardiovascular rationale. James was skeptical but willing to try anything that didn't involve additional medications. He purchased a contoured cervical pillow and a knee pillow. The first week felt awkward, unnatural. The second week started feeling more comfortable. By the fourth week, he was sleeping through the night for the first time in years, waking up without the usual neck pain. 6 months later, his sleep quality had transformed. He was getting consistently good rest, and his daytime blood pressure readings had improved, averaging 128/79 compared to 138/84 previously. His physician reduced his amlodipine dosage. James wondered how many years of better sleep and lower cardiovascular stress he'd missed simply because nobody had ever explained sleep position physiology. This raises the question that should be asked at every cardiology appointment, every neurology consultation, every primary care visit for anyone over 60 managing cardiovascular risk factors. Why isn't sleep position assessment a standard part of stroke risk evaluation? The answer returns to the same theme appearing throughout this presentation. The healthcare system is optimized for billable interventions. A sleep study examining apnea generates revenue. A prescription for blood pressure medication generates revenue. Telling a patient to sleep on their left side with proper pillow support generates zero revenue. Therefore, it doesn't appear in clinical guidelines, doesn't get taught in medical school cardiovascular curricula, and doesn't make it into the 12-minute appointment script. If there's agreement that this represents a profound systematic failure in patient education, that comment section needs engagement right now. Drop a comment saying, "I deserve complete information," if there's belief that healthcare should educate about free interventions as aggressively as it promotes paid interventions. Every comment tells the platform that seniors are paying attention and demanding comprehensive health education. Position number 2 approaches optimal configuration through adding temporal component to positional strategy. This involves not just sleeping on the left side with proper support, but also avoiding position changes during the critical early morning hours when stroke risk peaks. Research in chronobiology, the study of biological timing, has identified what researchers call the circadian variation in cardiovascular events. Stroke incidence follows a distinct temporal pattern with peak occurrence between 6 a.m. and noon. A meta-analysis, published in Stroke in 2022, examining data from 37 studies, including over 89,000 stroke cases, found that strokes occurring during morning hours accounted for 43% of all events, despite morning representing only 25% of the 24-hour cycle. The mechanism involves multiple converging factors. Cortisol, the stress hormone, surges during early morning hours, increasing blood pressure and heart rate. Blood viscosity increases overnight due to dehydration and reduced fluid intake during sleep. Platelet aggregability, the tendency for blood cells to clump together forming clots, is highest in early morning. These factors create a perfect storm of stroke risk during the hours immediately after waking. Position changes during this high-risk window further elevate danger. When transitioning from lying to sitting to standing, blood pressure undergoes rapid changes. In healthy younger individuals, cardiovascular reflexes compensate immediately. But in seniors with compromised autonomic function, the adjustment takes longer. During the delay, cerebral perfusion pressure, the pressure gradient driving blood flow to the brain, can drop precipitously. If this happens while transitioning from sleep position, particularly from right-side sleeping, which already creates higher carotid pressure, the combination can trigger ischemic events in vulnerable individuals. Research from the University of California, San Francisco, published in the Journal of the American Heart Association in 2023, monitored continuous blood pressure during sleep-to-wake transitions in 131 seniors aged 67 to 79 with existing cardiovascular disease. The study found that individuals who slept primarily on their right side and rose quickly upon waking showed blood pressure fluctuations averaging 32 millimeters systolic during the transition, compared to 14 millimeters in left-side sleepers who rose gradually. These pressure swings create mechanical stress on atherosclerotic plaques, increasing rupture risk. The optimal strategy involves maintaining left lateral position throughout the night, particularly during early morning hours, and implementing a gradual wake-up protocol. Upon natural awakening, remaining in left lateral position for 2 to 3 minutes allows cardiovascular systems to begin transitioning from sleep to wake state. Then, sitting up slowly, remaining seated at the bedside for another 2 to 3 minutes before standing. This graduated transition allows blood pressure regulation to adjust smoothly rather than creating the sudden pressure surges associated with rapid position changes. A pilot intervention study from Duke University, published in Circulation Research in 2024, taught this protocol to 87 high-risk seniors and monitored adherence and outcomes over 2 years. The intervention group showed 41% reduction in early morning cardiovascular events, including stroke, transient ischemic attack, and myocardial infarction, compared to matched controls receiving standard care without position-specific education.